paper by Dr. Sindhu Jha Murugesan, and she'll be talking on the efficacy of the intralesional bleomycin in the treatment of orbital lymphangiomas. Okay, please. Yeah,
Good evening. So I'll be talking about the efficacy of intralesional bleomycin in treatment of orbital lymphangioma. So coming to the introduction, as we know, lymphangiomas are benign hematomatous lymphatic tumors. So it's by the proliferation of anomalous dilated lymphatic vessels, which is lined by normal endothelial cells. So initially it was considered as a neoplasm, but ISSVA classified it as a combined vascular malformation. So 0.3 to 4% of all, it comprises of all the orbital tumors. There is slight female predominance is seen. And surgical excision is the mainstay of treatment, but due to the extensive infiltrative nature of the lesion, complete surgical excision is not possible and it can cause damage to the adjacent vital structures as well. So recurrence is also very common. Therefore, non-surgical methods such as intralesional sclerosing agents have been used. So our study we have used intralesional bleomycin in 16 patients diagnosed with orbital lymphangiomas. So they were diagnosed clinically and radiologically. All patients underwent detailed ophthalmological examination. MRI was done for all the patients. Systemic evaluation with blood investigations was done. Serial photos were taken and documented throughout the course of the treatment and follow-up. Exclusion was hypersensitivity to bleomycin, impaired renal function test and pulmonary problems, pregnant and lactating women, and patients who lost to follow-up. So bleomycin comes in a dried powder form containing 15 international units. 1 international unit of bleomycin is equivalent to 1 mg. The dose is 0.5 international units per kg body weight, and the maximum it should not exceed 5 international units per kg body weight. So it's usually prepared with normal saline and 2% lignocaine at ratio 1:1. So why lignocaine? It reduces postoperative discomfort and also it facilitates the dispersion of the drug, making the cell more permeable. So the volume injected into the lesion is usually 20% of the aspirate, and it should not exceed 5 ml at a session. So it's usually done under general anesthesia in children and topical along with sedation in adults. So the reconstituted solution is injected with a 23 gauge needle in a 10 cc syringe. For deep lesions, we have done under ultrasound guided and injection was done. So the aspiration, first the aspiration was done of the contents, which was sent for cytological testing. So the same needle was kept in the same position and bleomycin was injected. So what happens if you inject a larger volume? It causes extravasation of the drug, inadequate dispersion and compressive effects. So repeat injections were given at intervals of 4 weeks, and treatment was usually discontinued after a maximum of 3 to 4 injections or when there was no further sign of resolution. An MRI was done for all patients at 6 months after the last injection. So patients were under follow-up up to 1 year. So in our results, out of 16, 10 were females and 6 were males. 5 patients were in the pediatric group. All patients had unilateral presentation. Proptosis was the most common symptom, followed by lid swelling. So all the patients had 2 to 4 injections. 8 of them had complete resolution after 2, whereas 3 of patients required at least 4 injections for good satisfactory outcome. And 2 of them, after 3 injections, at 6 months follow-up, developed recurrence. And rest of the 3 patients, even after giving the maximum dose, there was no resolution and surgical treatment was done for them. So as such, there was no long-term or any serious systemic complications was noted in our study. So these are few patients. As you can see, there's upper lid swelling. So after 2 sittings of bleomycin injection, complete resolution is noted. Similarly for this patient as well. And this boy presented with proptosis. So after 4 injections, there was complete resolution, which was even confirmed radiologically. And this was pre-injection with diffuse lid swelling. And after 2 sittings, it reduced. And after 4, there was complete resolution. So this patient had no resolution and surgical treatment was done. And as you can see, at 1 month, he's very, very much clear. So I'll just rush through the discussion. So main thing in lymphangioma, it is the failure of lymphatics to connect to the venous system. And it will remain silent clinically or enlarge very slowly, causing proptosis, compressive optic neuropathy, EOM restriction. So in MRI, it has a pathognomic fluid levels. An absence of flow voids and enlarged feeder vessels will distinguish it from any hemangiomas or AV malformation. So bleomycin was first used as an anti-neoplastic and antibiotic. So how it works, mechanism of action is it breaks the DNA and also inhibits the DNA and RNA synthesis. It also induces tumor necrosis factor and apoptosis. There is also, it has a sclerosing effect on the vascular endothelium. So it was first used in 1977 by Ura and colleagues. So these are the adverse effects. Pulmonary fibrosis is dose dependent and usually occurs at the cumulative dose of 400 mg. So few studies which showed that bleomycin can be used as a very good drug for treatment of lymphangiomas. Raichura et al. Showed a dramatic response in 13 patients. So in our study also around 11 patients had good response, whereas only 3 required surgical treatment. So coming to conclusion, it's a very effective and a safe method for treatment of orbital lymphangioma without any significant ophthalmic or systemic side effects. It's also a good alternative to surgical excision where it's not possible to remove the tumor completely and when the patient is very much concerned about cosmesis. And it can also be used along with surgical debulking as an adjunct therapy. So these are my references. Thank you.
Okay, so how do you very surely pass the needle inside this cyst and remove it? So, and you classify into microcysts and macrocysts or something like that?
Not really. Mostly
Okay.
we usually see with the MRI itself we can know the location of the.
Yeah, you can
where it
localize the
is,
things,
yes.
but you
When it's
should,
very deep, we usually
as you
do
said,
it
you should pass it inside and you should aspirate the
Aspirate and
material
see,
and
yes.
then you should
Yes.
have the only 20% of the
only,
drug to be.
yeah.
So how do you manage that thing?
How
Pass
do you-
inside the cyst properly. You said you are doing it under ultrasound also.
Ultrasound guided for very deep
So,
lesions. Otherwise,
okay.
because as you can see, few clinical photos which I showed you, it was already
Okay.
seen extra.
So
I
you
mean,
are
in
able
the
to
preceptal
you are able
region
to
itself.
aspirate the material in all cases,
Yeah, mostly, yes, sir.
all the
All the
patients.
cases, yes.
Okay.
We do get good amount of aspirate.
Mhm.
Till
Okay.
now, we have not had any other due to the injection. We have not had any.
You don't have any
complication.
post-operative inflammation anytime.
No, it's very mild only. It's very transient also. Some patients we had a transient increase in proptosis, and
Okay.
some patients edema is there, but otherwise not very serious complications we have not had.
Mhm. Okay.
Thank you.